Okay, guys, thank you for your patience with these congenital defects. Let's just finish up a couple of quick slides here and then we will be done for the semester. So in continuing our conversation regarding defects that decrease pulmonary blood flow, we're going to pick up here talking about another defect called tricuspid atresia. Tricuspid atresia is a little bit different than any of the defects we've talked about already this morning, and that is because it's a complete failure of the tricuspid valve to develop. So that valve between, the right atrium to the right ventricle. And so what you see here is absolutely no communication from the right atrium to the left, I'm sorry, the right atrium to the right ventricle. So blood flows through an atrial septal wall defect or through a patent foramen ovale that hasn't shut from the right atrium to the left atrium. And then from the left side of the heart, there's a ventricular septal defect that blood can actually flow back into the right ventricle. So let me show you a picture here, because it's kind of hard to understand until you actually sort of look at the picture. So take a look here at this picture. This is what I was talking about. So here is the right atrium. There is no communication because of the way that the tricuspid valve did not form here. So it's just a wall, actually, that walls off the right atrium from the right ventricle. So the blood flows into the right atrium and then right out into the pulmonary artery. It does not go into the right ventricle at all. So then once blood goes out into the pulmonary arteries to the lungs, comes back into the heart in the left atrium, the left ventricle, and you see here there's like a septal wall defect right here that allows for some of this blood in the left ventricle to actually go into this little pouch or this little malformed right ventricle. So this is the malformation, the sort of the morphology of what you see with tricuspid atresia. So manifestations, in a newborn, you'll see cyanosis, tachycardia, shortness of breath, again, poor feeding. You'll hear the murmur. So all these manifestations should start sounding kind of familiar to you. Also with tricuspid atresia in an older child who's had this for a long time, you will start to see those signs and symptoms of chronic hypoxemia, like that clubbing that we just talked about. Treatment for tricuspid atresia, the palliative treatment is placement of a shunt to increase the blood flow to the lungs. But really the ultimate repair, the ultimate treatment for tricuspid atresia is a surgical repair that's staged, that consists of several different procedures that eventually connect the inferior vena cava right to the pulmonary artery. So it doesn't really even go into that malformed right atrium, right ventricle situation. That stage surgical repair, for those of you who will be working at Children's next semester or who have some pediatric experience, oftentimes you'll hear about that a lot, and it's called the Fontaine procedure, F-O-N-T-A-N. And again, it's a palliative procedure that diverts the venous blood from the right atrium right into the pulmonary arteries without actually passing through the right ventricle. So that's the treatment for tricuspid atresia. And again, many of you that will be having clinicals in the pediatric population at Children's next semester will see some of these defects, specifically tricuspid atresia. Okay, and again, there's that picture for you. Okay, as I mentioned at the end of lecture this morning, we're not going to spend a lot of time talking about mixed defects. You'll see that there's several slides from here on out of the lecture that are basically devoted to mixed defects. The one mixed defect that I did want to talk about here, and this will literally be where I stop, and will really only be the only mixed defect that you need to know, is transposition of the great arteries. So this is a really interesting phenomenon in which you literally have the great arteries being transposed. So what I mean by that is the aorta arises and leaves from the right ventricle, and the pulmonary artery arises and leaves from the left ventricle. So they've switched. So obviously, as you can imagine, what this does is it results in two separate yet sort of parallel circuits. So you have unoxygenated blood that continuously circulates through the systemic circulation because it never gets to the lungs. And then you have oxygenated blood that continuously circulates through the pulmonary circulation. So it only stays in the lungs and doesn't go out to the systemic circulation. So there's really no communication between them. So you ask, why is this a mixed defect? If you have these true, totally isolated parallel circuits that you never have sort of, oxygenated blood getting to the system and unoxygenated blood never gets to the lungs, why do we actually call this a mixed defect? Okay, well, we'll get there. We'll get there. Okay, so first of all, though, with transposition of the great arteries, obviously, from what I have just sort of described to you, extrauterine survival requires communication between the two circuits. So these are babies who are going for surgical repair almost immediately after birth, because as you can imagine, these two systems not talking to each other and not communicating is not consistent with life, if you will. So clinical manifestations of what this looks like in a baby who is born with transposition of the great arteries obviously depends on the size and associated defects. So there can be other congenital defects that we've already talked about that you'll also see in association with the transposition of the great arteries. But clearly these babies will be severely cyanotic. I mean, they're not getting any oxygenated blood. So I mean, that should hopefully make sense to you. And again, because of the lack of tissue perfusion and tissue oxygenation, you see lactic acid building up. They become metabolically acidotic. They're critically ill. And this, again, occurs right at birth. So for treatment, there's a lot of different surgical corrections that can be done. The arterial switch procedures are done quite commonly to make the left ventricle the systemic pump, and it may be the best of the various available procedures out there. But just to sort of give you that sort of explanation. Okay, the reason that we call transposition of the great arteries, oftentimes it is a mixed defect, is that usually there is some type of septal wall defect associated with the transposition of the great arteries that allows for some of the blood to mix. So again, that's why I said for the clinical manifestations, it depends on the size and other associated defects for how sort of affected someone is. If there is some type of septal wall defect that does allow for some oxygenated blood to get get mixed over and to get pumped out of the blood or pumped out of the heart to the body, you can allow for some oxygenated blood then to get to the body, which is why we call this a mixed defect. And obviously those babies will be less cyanotic than the babies who have a true isolation of the two sides of the heart. And here's a good picture for you. So you see here the aorta comes off of the right side of the heart, and the pulmonary artery comes off of the left side of the heart. And here's just a good illustration of you have the circulation of unoxygenated blood that just kind of keeps getting recirculated and recirculated and recirculated, and it never gets oxygenated because it never gets to the lungs, because it just keeps going to the body. Or you have this circulation, I should say, or you have this circulation down here of the circulation of oxygenated blood that just keeps going from the left atrium to the left ventricle to the pulmonary arteries to the lungs and back. Now, it's a mixed defect because oftentimes you'll get mixing of blood via several different defects. So either through an arterial septal defect, or an atrial septal defect, a ventricular septal defect, or through a patent ductus arteriosus. So that's why we call this a mixed defect, because oftentimes there are defects associated that actually does allow for some mixing between these two isolated circulations. So I hope that makes sense. Okay. So yeah, so A here will show you the sort of the morphology or the visual of a complete transposition of arteries with no septal defects. So there's no defects here allowing for mixture. And this is sort of the visualization of sort of the pathways in which there may be some mixing going on. Okay? So again, we will stop there. The rest of the mixed defects you will not be tested on for the exam. And as I mentioned at the end of class today as we were finishing up, at the very end here, I do have this summary for you of the different congenital heart defects. So the acyanotic versus the cyanotic defects. And a lot of these obviously are ones that we talked about today. Okay? All right, guys. Thank you very much. Happy studying.